In this short video, we are going to talk about the new ASA guideline, which has recommended endovascular stroke therapy, which has been published online on 29th of June 2015. It is once in a generation advance in the treatment of acute ischemic stroke. Why are we talking about it? After ischemic stroke, all of us know that there is a penumbra zone, a zone where brain cells are still revivable, but they are not functioning because of the hypoperfusion. And now we know that for many hours, even up to 12 hours or up to 24 hours, patients can have a penumbra zone, and which, if we can recanalize the blood vessel, restore the blood supply, then patient can lead to have better clinical outcome. But if you don't, then this penumbra zone becomes an infarcted zone, and the infarcted zone expands over the time. So we have a limited time period, limited window in which we can do these procedures and try to get the patient better. IVTPA is a known standard treatment of ischemic stroke, but there are many issues. One is time factor. IVTPA is effective only up to 4.5 hours of stroke. In large vessel occlusion, it is not very effective when there is a large clot burden, or it takes too much time to recanalize. There are many contraindications such as anticoagulants, recent surgery, or wake-up strokes, and ultimately less than 5% or in best of centers up to 10 to 15% may qualify. And this is the data which shows how in large vessel occlusions IVTPA can be quite ineffective. This is the data from clot bus trial, in which it shows that in the ICA or MC occlusion, the recanalization rate varies from 6% to 30%, which is quite low. And this is one of the meta-analysis published in Stroke Journal, which again showed that while overall IVTPA, the recanalization rate may be 46%, in intra-arterial TPA or urokinase 64%, mechanical goes up to 84%, and good outcome is seen more in the recanalized patients. So there has been a huge issue how to handle this patient with large vessel stroke. This is where the mechanical recanalization has come in. So in which patient do we really want to do it? We are talking about major vessel occlusion, not for minor vessel occlusions. And when IVTPA is ineffective or contraindicated, and by and large we are using stent retriever technique in these cases, as the picture shows. And by some technique we try to document that there is a major vessel occlusion and there is a penumbra present to intervene in these patients. And this is the new ASA guideline, which has recommended endovascular stroke therapy, and which has been published online in Stroke in June 29, which is an update of the 2013 guidelines for early management of patients with acute ischemic stroke. And it has given strongest recommendation possible, a class 1 level of evidence A for certain stroke patients to receive endovascular treatment. And this has been based on these recently published trials, which are all randomized trials: MR Clean, Escape, Extend IA, Swift Prime, and Revascat. Now, what about the imaging in these guidelines? In the imaging, these guidelines say have a simple strategy of confirming the presence of a clot in a major artery and using non-invasive computed tomography whether there is salvageable brain tissue. Although in each trial there was a different protocol, including CD perfusion to use of CT angio assessment of collateral presence. Now, this is the overview of all of these trials, and what you see here in the terms of control group versus intra-arterial group, and what is outlined is the difference in the clinical outcome, MRS02. In MR Clean, the improvement was from 90% in control group, and good outcome was seen in 33% intra-arterial. In Escape trial, 29% versus 53%. In Extend IA, 40% versus 71%. In Swift Prime, 36% versus 60%. And in Revascat, 28% versus 44%. All the cases were significant, with no increase in hemorrhage rates and with an improvement in mortality rate as well. And this is a more pictorial presence showing the black showing the recanalization rate, and in the darker gray the MRS02 outcome in the intra-arterial group, and the lighter shade the MRS02 outcome in the control group. And in all these trials you say there was slight variation in the achievement of the recanalization, but all the trials show significant improvement or significant better outcomes in the intra-arterial group versus the IVTPA group. And the below line shows the time at which they started the procedure, and that also varied within trial, and the best timing were achieved in the Escape trial. So what do the guidelines really say? Now, guidelines say that the patient should receive endovascular therapy with a stent retriever if they meet all of the following criteria. If the pre-stroke MRI scale was 0 to 1 and patient received TPA within 4.5 hours of onset, patient have an occlusion of M1 or MCA or of internal carotid artery. Although they have also recommended that in selected cases of M2 occlusion, vertebral basilar artery PC occlusions, one can do it. Age is 18 years or older with the NHS score of 6 or greater, with the aspect score of 6 or greater, and treatment that can be initiated the groin puncture within 6 hours of symptom onset. What are the bottom line messages? But these results, number one is, it's clear that we have to get this patient fast to a stroke center and TPA should be given. But within this group, the patient which can fit in within the endovascular therapy should be considered for intervention, and they should be taken to a comprehensive stroke center where endovascular treatment can be done. And therefore, it is a very necessity that we have to develop hub and spoke model for acute ischemic stroke so that TPA can be given at peripheral centers and the patients can be quickly taken to major centers for intra-arterial treatment. So this is just to show patient with suspected stroke, go to a primary stroke center, receive IP TPA, and once you meet the eligibility criteria for intervention, quickly transported to comprehensive stroke centers and should receive endovascular treatment as well. Just to show you a few examples of from our experience, this is a patient who had a previous history of a coronary artery intervention, was admitted for surgery for aortic stenosis, the anteoperative was stopped, and patient had a major stroke in hospital. The CT scan clearly showed no major infarctions, and CT angio showed occlusion of the left middle cerebral artery in the M2 region. IV TPA was given, but there was no improvement, so we took the patient immediately for intra-arterial intervention. The DSA showed the occlusion of the middle cerebral artery, major division, and the solitaire was placed. Soon after the solitaire was placed, the perfusion started, the artery started to flow, and then we took out the solitaire along with the clot, which can be stuck with the device, as well as came out in the aspiration, and which led to complete recanalization of the patient's blood vessel. And the follow-up CT scan shows a very small area of infarction. Patient was completely well and recovered to his normal status. Another patient with even a bigger arterial occlusion. This is a patient who presented with severe hemiplegia with 0.5 power on the left side. The CT scan showed hyperdense ICA and the MCA. CT angio shows that there is a major vessel occlusion and the ICA is completely occluded along with the middle cerebral artery in the intracranial circulation. And as is our practice, we use CT perfusion to decide whether there is penumbra. So the first image is of the CBV image, which shows a small infarct in the basal ganglia area, while the CBF and the MTT, the last two images, show the large area of hyperperfusion in the middle cerebral area territory. So this patient is a very deserving candidate for intervention. The DSA shows the ICA was occluded. We went through this ICA, we placed the solitaire device in the clot which was in the distal ICA in the MCA, and you can see immediate some flow started, and then we took out the clot using the solitaire device. We led to complete recanalization of the intracranial circulation and of the internal carotid artery, and the follow-up CT scan shows a small area infarct in the basal ganglia with a contrast diffusion in the infarcted area. Patient with time made a complete recovery. So we just want to emphasize in the end that truly, this has been like a holy grail of neurointervention to prove and to have acquired the knowledge how to benefit a patient with acute ischemic stroke, and we are the lucky generation where we achieved that. But the bigger challenge remains now to establish this stroke intervention program all over the country. Thank you.